Well, good morning. It's really a great pleasure to be here in Newfoundland and Labrador, and I have a lot to say about social isolation and loneliness, so I'll move pretty fast through this talk. I won't dwell on every slide, but I want to give you, it's kind of a journey through this topic, and our team at CCSMH has been working on this now for, I guess, about a year and a half, and it's a fascinating process trying to create guidelines where none exist. These are my disclosures. So I do have grant support from a number of organizations, mostly through CCSMH. My other disclosure is that I was born and raised in Dublin, Ireland, and island to island. So yeah, you know, Newfoundland and Ireland were at one point actually connected. So you might hear my Irish accent coming out a bit more than usual, especially after getting screeched in last night. So, but I feel very much at home here. It's a beautiful place. So, you know, part of what I'm talking about is this project that we're working on, but the talk goes beyond that for sure. And it's fascinating that we got funding through a private foundation, an anonymous private foundation. They are generous, but they don't want any recognition. First time that's ever happened to us, and it's a really a good fit between this particular foundation and CCSMH. They like what we do. They thought that we could bring something that would be valuable in this area. So it's a 2-year project. It ends next March. So, and I want to acknowledge our Canadian working group to create the guidelines. We have a fantastic team from right across the country, some true experts in this area, and as well as our staff and a couple of consultants who've been working with us. So if you're interested, we're having a workshop on this, on the actual guidelines right after this, and you can meet our whole team there. So, learning objectives. So by the end of the presentation, I'm hoping you'll be able to list the negative health impacts associated with SI and L, I'll call it that. Be aware of developing international approaches to reduce SI and L, and to be able to reflect on how you can assess factors that contribute and then recommend appropriate interventions. So this is what I'll go through. So Mother Teresa said that the most terrible poverty is loneliness and the feeling of being unloved. And the US Surgeon General, Vivek Murthy, said, "We live in the most technologically connected age in the history of civilization, and yet the rates of loneliness have doubled since the 1980s. Fascinating in that he was the Surgeon General. He got fired by President Trump, and he's now back with President Biden. So an amazing guy, and he's really as you'll see later on, he's really made this one of his key areas. So how do we actually define social isolation and loneliness? That's certainly important. So social isolation is a measurable deficiency in the number of social relationships that a person has. So it's a very objective thing, although there's different ways of measuring it. Loneliness is subjective. It's an internal, subjective experience. It's unpleasant. It's felt when a person's social relationships are lacking in quality or quantity compared to what they desire. So they're overlapping, but they're not the same thing. And this is a sort of source of confusion, really, because the literature, by and large, lumps them together as if they are the same thing. And I think we in mental health, or health in general, would say, I don't think they're the same thing. And yes, this is Canadian data here, and what it says is that some people are very isolated but not lonely, and vice versa. Some people are very lonely but not isolated. So that tells us something about the fact that they are not the same. So, and there's different types of loneliness, many types. Social, emotional, existential. It was Robert Weiss in the 1970s who separated social from emotional. And really where the social sounds a bit more like social isolation. It's an absence of social connection, whereas emotional is an absence or loss of meaningful, deep, meaningful relationships. And then the existentialists, philosophers, would say that loneliness is an inevitable part of being a human being, an aspect of the human condition which expresses the separateness of the person from others. There's even something called cosmic loneliness, which is the feeling alone in a hostile universe. And then, of course, we all know about lockdown loneliness, right? And social connection, of course, can be looked at in different ways. It's the flip side of isolation. But it can also be broken down into structural, functional, and then the actual quality of relationships. This is from the UK, and of course, we all experienced, or maybe not. Let's actually ask the group. During the pandemic, okay, this is for you to reflect on. So did you personally experience some degree of social or professional isolation during the pandemic, yes or no? Did you feel lonely for significant periods during this time? And then clinically, when doing a new assessment, how often do you actually ask patients specifically about loneliness? Always? Most of the time? Kind of often or occasionally? It's an interesting question. When I asked this question before, by the way, I was really surprised at how many health professionals said that they had experienced significant loneliness during this time. So the German-American psychiatrist Frieda Fromm-Reichmann in the 50s said that there's a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject of loneliness. And thus it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. She said, loneliness seems to be such a painful, frightening experience that people will do practically anything to avoid it. Do you agree? It's often artists and musicians who've captured this topic. Virtually every group of people on Earth, no matter what they do, have some perspective on this topic. But the Beatles, Lennon and McCartney, those words are pretty powerful. I'm sure you can imagine that song. I'm not going to sing it, but. Now, the case example for today is the artist who painted on the left there. Her name was Kay Sage. She was an American surrealist painter. And she was married to Yves Tanguy, who is a French surrealist painter. Very interesting background. She came from a wealthy American family. Her parents split. Her mother moved to Italy. She went with her mother. She learned how to, she went to art school there. She had a first marriage that failed, and then she met Yves Tanguy, and it was an explosive, powerful relationship. Some abuse, apparently. He was pretty aggressive at times and unpredictable, volatile, but nevertheless, they were soulmates. In 1955, he died of a stroke, and she painted this painting the following year. She was in her 60s at the time, or around 60. And I think it's a very powerful painting. I don't know what you think about it, but does it suggest loneliness to you? You could think of it in other ways. It's a projective test, but I think it does evoke a lot. And now unfortunately, this case history is a sad one because she really became deeply depressed. She was extremely lonely without him. She also developed severe cataracts and had failed cataract surgery, so she could no longer paint very much. She wrote poetry as well. In 1963, she wrote a suicide note saying she was going to be reunited with Yves, and she shot herself. So powerful, yes. A quiz question. Is loneliness included as a criterion for any mental disorder in the DSM-5? Yes or no? How many would say yes? Not too many, right? Anyway, okay. The answer is yes. It's one of the 8 criteria for prolonged grief disorder, which includes an intensive yearning or longing for the deceased person, preoccupation with thoughts and memories of the deceased person, plus 3 of 8 criteria, including intense loneliness. Now, that's the only place where it's mentioned in DSM. What are the risk factors for loneliness and isolation? Of course, there are many, but these are obvious. But living alone, having impaired mobility, experiencing a major life transition, low income, being a caregiver, having psychological or cognitive vulnerabilities, living in a rural location, having neighborhood community limitations, small social network, speaking language other than English, and belonging to a minority group. This comes from the Campaign for Ending Loneliness in the UK. I just thought this was interesting. It was it's just a descriptor, but it says, one of the key lessons learned in Middlesbrough in England is how entangled loneliness is with other problems. They found that loneliness is intertwined with other significant issues, which include, but are not limited to, childhood trauma, long-term physical health conditions, unemployment, caring responsibilities, substance misuse, domestic violence, and poverty. This showed loneliness is not a standalone issue. It's a piece of the bigger picture. But before we get too immersed into isolation, what about solitude? Is it all bad being on your own? No, actually, there's quite a bit of evidence that being on your own may actually be quite good for your health. Some would suggest that it can increase empathy, increase productivity, spark creativity, build mental strength, give you an opportunity to plan your life. It may be good for children to spend time alone. And it helps you to know yourself. Recent study, Happy Alone, Motivational Profiles of Solitude and Well-Being Among Senior Living Residents. In their conclusions, they mention that these findings suggest that positive motivations for solitude, characterized by intrinsic desires to spend time alone for reflection, restoration, or personal interests, do not pose risks for older adults, and on the contrary, are associated with levels of well-being comparable to people who prefer greater levels of social interaction. So, this is interesting. This is from Green Day, Walking the Lonely Road, but this is a different feeling. This is where loneliness, it's home to me and I walk alone. It's got a different feeling. A person's more at home, perhaps, with that sense of loneliness. Although there is the boulevard of broken dreams. The downward spiral of loneliness, this comes again from the psychology of loneliness in the UK, and really it's all about negative thoughts, building on more negative thoughts, which influences behavior, which makes you less interactive, and more negative thoughts, etc., etc. There's an evolutionary theory of loneliness from John Cacioppo, the late John Cacioppo, who's one of the sort of gurus in this area, done a huge amount of research. I like this quote: "If you want to go fast, go alone. If you want to go far, go together." But our survival and reproduction often depend on our ability to form and maintain social bonds. So there's an evolutionary theory about why loneliness might be good for us. It might propel us to actually propagate. So, what is the prevalence of social isolation and loneliness? You think that's an easy question to answer, right? Well, it's not. It turns out that studies on the effects of age, gender, and culture have been really inconsistent. It's generally assumed that loneliness increases with age, although recent studies report that young people are reporting the most loneliness. In some studies, loneliness levels tend to be elevated in midlife. Others find the opposite. So it's actually quite confusing. Angus Reid's survey in Canada, about half of all people say they have some degree of loneliness. 1 in 5 would say they're very lonely. And similar kind of numbers around social isolation. Studies, the Canadian longitudinal study of aging, have been measuring this for different time periods. And when they looked at these numbers in 2020 during the pandemic, the numbers shot up, so quite significantly. And among older adults, the greatest increase was among women 65 to 74. So a lot's been mentioned now about sort of social isolation and loneliness as medical issues. And this comes from Julianne Holt-Lundstad and colleague, published this year in the New England Journal of Medicine. I will read this out. Social isolation and loneliness are rarely listed on death certificates, yet they may have contributed to the excess deaths from all causes observed during the pandemic. Although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. Patients' lives may hang in the balance. That's pretty powerful, and it was, published in the New England Journal of Medicine. So, is that accurate? Is it excessive to say that? This image comes from a really excellent document produced by the National Institute of Aging here in Canada. It's a great document. But this summarizes the data on the consequences of social isolation and loneliness for older adults from lots of different studies showing pretty scary associations here. So increased risk of stroke, increased risk of coronary heart disease, increased risk of cancer mortality, 50% increased risk of developing dementia, increased risk of functional decline, 59%, and a 45% increased risk of death. How is this possible? There are theories that, that this could relate to lifestyle factors, psychological factors impacting biomarkers, medical adherence and compliance, all of this coming together to potentially affect morbidity and mortality. This is from Kakiopo, and they've done a lot of biological studies on the associations between loneliness and a whole variety of changes, biological changes, everything from inflammatory substrates to viral immunity, even transcriptome dynamics, changes in genetic factors, all of which may impact mortality. But I don't think we want to think about loneliness and social isolation as some sort of biological, medical issue alone. That would be a very narrow view. And when we look at the core determinants of health, social support networks and social environments are considered to be key core determinants of health. Of course, loneliness and mental health are totally connected. An interesting quote from the Harvard study of adult development, that close relationships, more than money or fame, are what keep people happy throughout their lives. This is a very longitudinal study. Those ties protect people from life's discontents. They help to delay mental and physical decline and are better predictors of long and happy lives than social class, IQ, or even genes. That finding proved true across the board among both the Harvard men and the inner city participants, so right across the social spectrum. So it's a two-way street here. It's bidirectional. Obviously, loneliness can decrease mental health and vice versa. There's a recent publication from Jesty and colleagues in American Psychiatric Press, Science and Practice of Loneliness. This is from one chapter in there by Tiburica. Loneliness in marginalized communities. Really just, this is in the US, but just stating that there's a lot of data that loneliness is more common among a variety of marginalized US communities, that immigrants are at higher risk, and they suggest that one should look at acculturation strategies, because this can contribute, and that marginalized groups commonly face health and healthcare inequities, and clinicians must focus on ensuring access to necessary community resources. Now, it is Truth and Reconciliation Day. I wanted to highlight for you a document on social isolation of seniors, a focus on Indigenous seniors in Canada. This was produced by a federal agency and was published in 2018. And there's a lot in here. It's a very useful document. And it does emphasize the long history, the challenges. They say that Indigenous seniors are considered at high risk of experiencing social isolation due to factors such as racism, marginalized language, culture, poverty, and historic negative experiences. And they talk about the trauma, of course, of residential school experiences that's built upon the trauma from earlier forms of injustice and oppression and continues. In this document, though, they highlight a variety of protective approaches, particularly those that would be not just good for all seniors, but additional factors for Indigenous seniors. And these focus a lot on cultural issues, respect, belongingness, participating in ceremonies, for example. It's a very useful document, and you may want to take a look at it. So what about international perspectives, and how are we doing in Canada, of course? So Kiefer Card is from British Columbia, and he is one of the leaders of the Canadian Alliance on Social Connectedness and Health. So, and this is a very interesting organization. They've done their own surveys, they're actually working right now on guidelines on social connectedness. So we're doing social isolation and loneliness, but he and his group are approaching it from the other angle, which is, well, what should the guideline be in terms of, you know, a minimum amount of social connectedness? So it's going to be very interesting to see what they come up with in relation to what we come up with. So, but he published a review looking at international approaches, and they basically concluded that really it's only the United Kingdom that's really done anything really serious in this area. Other countries have kind of said this is important, and their comment on Canada is that the federal government has no strategy or policies to address loneliness specifically. Statistics Canada has conducted research. Quebec has published a strategy to address loneliness among seniors related to the pandemic. Yes, it was the United Kingdom that appointed a minister for loneliness, and they've done a lot of work in this area, and they have invested in it, and they've published all sorts of very interesting, useful documents, mostly in the grey literature. This is just a list of things they've done, and it shows that they put money into it, and they're really thinking it through, and they've taken it seriously. Now, there may be some skeptics that say that this is all politics, and they just wanted to make it look good. I don't know what the truth is, but they are certainly serious about it. And they've spawned all sorts of community programs right across the UK, and it's worth reading their materials. Interesting. Their campaign is a campaign on loneliness. It's not a campaign on social isolation. Of course they overlap, but they wanted to highlight the loneliness side of it. It's the National Campaign for Loneliness, okay? There's a global initiative on loneliness and connection with a lot of, several countries coming together to work on this issue. From the United States, the National Academy for Sciences, Engineering, and Medicine produced a very excellent report on social isolation and loneliness in older adults, Opportunities for the Healthcare System. So that whole document talks about how the healthcare system can contribute. And then the US Surgeon General recently published a document, really a call for action, entitled Our Epidemic of Loneliness and Isolation. Another good document. The World Health, the WHO, has published also an important document stating pretty much the same things as everyone else. This paper came out recently. I was really excited by this. The prevalence of loneliness across 113 countries, a systematic review and meta-analysis. I thought, okay, everything's going to be in here. And what they basically say is they don't have nearly enough data to make any real comments on this topic at all. And it sounded so great. But they did say that a geographic pattern for loneliness prevalence was found with Northern European countries consistently showing low levels. I thought that was weird. And this is not from their paper, but it's similar. This suggests that Mediterranean countries like Greece, Israel, and Italy have the highest levels of self-reported loneliness compared to a whole variety of other countries, including sort of Central and Northern Europe. Do you guys believe that? Do you? I really wonder about it. But it could be, I don't know, perhaps people in Mediterranean countries are a bit more aware of their emotions or willing to express them. That's my theory anyway. So, well, on another tack, when we go into space, when we're on our way to Mars, it's going to be lonely. You may have a couple of companions along the way, but you're going to be very far from Earth, and the further you go, the longer it's going to take to connect. You may not be able to connect at all. And so, NASA and the Canadian Space Agency have been looking at this and studying this. Believe it or not, yes, because this could be critical in terms of the success of these missions. And they've come up with strategies that can help astronauts deal with isolation. And they've studied it. For example, this paper on external communication of autonomous crews under the simulation of interplanetary missions. They've actually put astronauts through a simulated period of isolation in a small group and looked at how they interact. They're particularly interested in the difference between men and women in this regard. It's quite an interesting paper. So that brings me to our project, and what are our deliverables? Our deliverables are, of course, lit review, creating the working group, and then stakeholder engagement. So we've carried out 2 national surveys that we reported on yesterday. The first was with health and social service providers themselves. We wanted to find out, what do these folks really think about this topic? And we got some really interesting feedback. And then we did the second survey with older adults themselves. More than 2,000 responded. Again, really interesting findings. We're going to create the guidelines, disseminate them, create knowledge translation tools, raise awareness. Clinical guidelines, of course, can be beneficial. I won't go into the details. It's a long process to create them. Several CCSMH groups working on this right now. We're getting there. First thing you do is review existing clinical guidelines, and there aren't any. So that was quick. The NASM report does have a few recommendations. Again, it is focused on healthcare, so that was helpful. And the one thing they did say, I won't read this, but basically they say that for older adults who are currently social isolated or lonely or at elevated risk, we should discuss the adverse health outcomes with them. Okay, so tell them this is not good for your health. And then for those who are currently isolated or lonely, we should attempt to determine the underlying causes and use evidence-based practices tailored to address those causes, such as hearing loss or mobility limitations. So Celinda Horgan and Jeanette Prorick have helped us with our lit review and also helped us with the surveys that we carried out. And we looked at 4 types of information. We wanted to look at practice interventions, at promising practices, at patient experience, and screening and assessment tools. When it comes to screening and assessment tools, there are a lot of them out there. Most of them have been used in research, actually not in clinical practice, which is challenging for us because it means it's hard to come up with recommendations. Now, Nancy Newell is our expert on this. She's from University of Brandon, in Manitoba, and she really knows this area and has done some really novel work. Anyway, we found there were 15 scales. They varied in length from 3 items to 70 items. Which one would you prefer in clinical practice? And 10 of the 15 have actually been validated in older adult populations. This one, the 3-item loneliness scale, is very popular. It's used in many different studies, and it would be a pretty useful one, I think, in clinical practice. One of the interesting things is if you read those 3 questions, even though it's a loneliness scale, they don't actually use the word loneliness or being lonely. Isn't that interesting? Think of what Frieda Fromm-Reichmann said. Are we afraid to ask people? And then Nancy and a colleague of hers have come up with a great scale called the CARED scale. That's the acronym, which looks at connections, activities, relationships, emergency contacts, and dwelling, where the person actually lives. And they've come up with some useful tools. This actually looks at both loneliness and isolation. Most scales look at one or the other. So, which interventions show promise? Well, Leonard Cohen said, there ain't no cure for love. The doctor's working day and night. They'll never find that cure for love. There ain't no drink, no drug. Nothing pure enough to be that cure for love. So is the cure for loneliness so elusive? I thought I'd ask ChatGPT just to see, you know, scarily good. This is exactly what it said just a few days ago. ChatGPT said, loneliness is a complex and subjective emotional experience, and there's no one-size-fits-all cure. However, there are various strategies and approaches that can help alleviate loneliness and improve one's social well-being. It says that loneliness can be influenced by various factors, including personality, life circumstances, and personal history. Again, a combination of strategies. And ChatGPT does say seeking professional help from a therapist or counselor is a valuable step. And then, 10 suggestions. These are not bad, I tell you, you know. And just in case they miss it, they again say, look, you may want to seek professional help, you know, if things are getting really bad. So I don't know why we're bothering to do these guidelines at all, you know, really. It's kind of scary, isn't it? I mean, honestly. So we're doing our review. We found 38 reviews that were systematic or scoping reviews, and they looked at a variety of different possible interventions, as you see on the left. I was interested, though, in which interventions are most effective for loneliness itself. Okay, and there is some indication that interventions that target social cognition can be particularly helpful, so CBT-like approaches, social skills training. An Italian group, Veronese et al., did an umbrella review of this, and they again said social cognitive training, social support, or meditation and mindfulness. There's some evidence, low levels in terms of strength of evidence, but those were the things that really stood out. So I think that's worth remembering. Our review has looked at promising practices, so that's more the gray literature, and they highlighted that approaches should be patient-centered, collaborative health and social care working together, tailored services for diverse populations, and the use of technology in appropriate circumstances. What about patient experience studies? Not a lot available, but they pulled out a couple of barriers that were identified, so difficulties in locating and accessing appropriate services, lack of personally meaningful and culturally appropriate intervention activities. So the overall challenges, looking at the literature as a whole, were that there's a variability as to whether isolation and loneliness are treated as singular or distinct concepts. Again, that is an issue and a challenge. As always, methodological inconsistencies, variability in outcomes and outcome measures, and a lack of research regarding the impact of isolation and loneliness interventions on diverse populations of older adults. There's really not a lot in that area, and then very few patient experience studies to draw on. I'll just mention this, though, and this is an interesting and useful review by Jennifer Bethal, Toronto, University of Toronto, and colleagues. They specifically looked at interventions in long-term care homes, so it's an excellent review of this topic. And sort of no big surprises here, perhaps, except that managing pain was one of the areas that stood out, with some evidence that may be important. So in addition to all of the other types of interventions, including visit with pets and using technology and so on. So this is a really excellent review specifically of interventions in long-term care. I'm not going to say too much about what our actual draft recommendations are at this point, but you may want to come to the workshop afterwards where we're going to be talking about some of this. But one of our important recommendations is about assessment. So really the need for a comprehensive assessment is critical. And, you know, family doctor might say, there's an awful lot in there. How am I possibly going to do that? And I think family doctors know how to hone down on the issues that are really critical. But thinking as a checklist of things that you might want to consider, I think, is really, really important. And we thought it was important to, when it comes to interventions, we have some recommendations that look at the overall approach. So we strongly emphasize that providers should apply principles of shared decision-making. So we want to empower older adults where possible. An individualized approach is critical. We recommend that clinicians identify individuals' interests to determine the interventions that may be the best fit while balancing the available resources. And the intervention should take into account the individual's culture and recognize the diversity of older adult populations. And then we should first and or currently treat underlying medical conditions identified in their assessment. So if the person's depressed and lonely, you're going to want to treat that depression, right? This is, so our recommendations around interventions are included pretty much in this list here. Each one of these has a variety of different components to it, but this is the list. And we did include a recommendation on pharmacological treatment of loneliness. You might see in the media that there's now ideas that you can treat loneliness with medications. That Kakiopo's he passed away, but his partner is continuing his work, and they've done so much biological studies. They've actually suggested the use of let me get this right. There's a medication that's called allopregnanolone, which is the medication that's been released for postpartum depression recently by the FDA. And some people have said that could be a very good treatment for social isolation and loneliness, particularly loneliness. So anyway, we have a strong recommendation not to use pharmacological treatment for loneliness alone. But of course, if there are other conditions like depression, then yes, of course we want to treat it. So in the last few minutes, I'm just going to say that in terms of interventions, of course, there's interventions at the individual level, and that's what our guidelines are pretty much about. But there are also interventions potentially at the community level and at the society level. I mean, a national campaign like the UK has is looking at the national, they're looking at the whole society, particularly how to prevent loneliness and isolation. This is from Vivek Murthy, the Surgeon General of the US. This is the 6 pillars to advance social connection. So this is their advice. Number 3 is mobilizing the health sector, so that's us. But they have a whole variety of other approaches as well, strengthening local communities, pro-connection, public policies, reforming digital environments, so dealing with the digital literacy issue, deepening our knowledge, more research, and building a culture of connection. This is from a chapter in that recent book that Justy and colleagues released by Van Orden and Conn, suggesting that if you know what the underlying cause is, that could direct you to various interventions. Makes sense. And then Holt-Lundstad and colleague have a simple framework for addressing social isolation and loneliness. This is again from the New England Journal of Medicine. The EAR approach: educate, assess, and respond. And so there's some very simple ideas here that make sense. And finally, you know, we may say to people, we really think you should change your behavior. We really think you should have more, go out and socialize more, have more friends, and do this or do that. But you know, people have habits. It's very hard to change habits. I love this this cartoon. No one's keen on actually changing. and a shout out to the Fountain of Health. Where's Kerry Lee? And yeah, you know, I mean, when it's important to assess a patient's motivation and to help them make changes. And the Fountain of Health approach is an excellent approach to setting goals. And so I think, you know, we can come up with all sorts of interventions and advice and strategies, but ultimately it's going to be setting goals and making changes and working with the person, following up. So I think that's really important. So in conclusion, some key points. There are multiple perspectives and theories regarding, this is a massive topic, regarding social isolation and loneliness. The prevalence data related to age, gender, and culture are inconsistent. There is a strong association between social isolation and loneliness and poor health outcomes. Our clinical guidelines will be the first to address this issue. There are many possible interventions for healthcare and social service providers to consider. An individualized approach and shared decision-making are essential in clinical practice. Solutions are possible at the society, community, and individual level. And a few countries, such as the UK, are taking a national approach. And a question to you: what approach should Canada take? Here's our emails. Betty, our project manager, would love to hear from you as well, as I would. And I'll stop there. Thank you so much.
Thank you so much, David, and the social isolation